Hi everyone, and welcome to ABCs of Anaesthesia. I'm Lahiru, and for this installment, I'm going to go through some of the structures and frameworks that have helped me from my first year of anaesthesia training through to the second part exam. Now, this is the first time I'll be recording this as a YouTube video and a podcast to try and give you the opportunity to choose the medium that best suits your needs. And as always, I'll post relevant information and links in the notes below. So the aim of having really good frameworks is to have a robust structure on which to attach the million odd data points you will acquire through your training. Medical training is often opportunistic, and any individual byte of information will soon be forgotten without context. That is why medical training transitioned from a rote learning model to a case-based learning model to give context and a story to the multitude of facts you will acquire over the decades of your career. So in this installment, let's go through some of the important frameworks that I wish I had paid more attention to in my training that would have made the journey a lot more structured, more meticulous, and improved my performance in exams and assessments. I'll now outline all the frameworks we'll talk about. I'll provide examples and context as we go through these frameworks. Firstly, the pre-op, intra-op, post-op framework and the anesthesia, surgical and patient issues frameworks are always useful, but I think we can supercharge this to make it more detailed. Some questions are best suited to one or the other, but I find a chronological approach is best to give a complete answer, so we'll start with that. So chronologically, pre-op, intra-op, post-op works very well. Pre-op starts with the assessment. You're called to attend a patient. Now that first decision is, are they sick or well? If they're sick, you go through the deteriorating patient framework, which we'll go through in another session. If they are relatively well and stable, the assessment of the well patient is with history, examination, and investigations. The AMI assessment framework is SSCCT, and that stands for severity, stability, cause, complications, and treatment. The additional cancer assessment is the 5Ms framework: mass, METs, medications, metabolic, and mental state. Now, causes of anything. This is not exhaustive but helps to consider random causes, and that's the SCANDIT framework, so SCANEDIT. Now, the next part of pre-op, we've already done assessment. The next part of pre-op is scope, SCOPE. So after assessment, all of these tasks before we go to theatre are S for suitability, C for consulting medical and surgical teams, O for optimize, P for PRIMADE, and E for explain or consent. The intra-op framework is PRIMADE time, and finally post-op is simply AD, or analgesia and disposition. Now, this is not an exhaustive list, but I'm being brief, and I will go through each section in far more detail in future videos and podcasts. So number one, the assessment of the well patient framework. How do you assess this patient's pain? How do you assess this patient's fluid status? And how do you assess this patient's airway? The answer is always history, examination, investigations. Now, side note, it's important to emphasize that this is for the well patient. As soon as a patient looks unwell or you're unsure if they're well, you have to use the deteriorating patient framework. The deteriorating patient framework allows you to identify and treat problems rapidly to keep a patient safe before going into the details of a definitive diagnosis. For example, if the airway is obstructed, you apply maneuvers, adjuncts, and advanced techniques to remedy this. If the SATs are low in breathing, apply oxygen and assist ventilation as required, etc. So, if your patient is well, I would assess using a history examination investigation approach. This is often a throwaway line, but imagine if you were to forget one of these crucial elements in an exam or in real life. So I often ask trainees about how they would assess this airway, and it's very easy to forget that the best indicator of a difficult airway is rarely the examination findings. It's the previous airway management history that's on any anesthetic chart. A complete answer to that question would sound like, I'd do a history examination investigation of the airway, I'd review the patient's previous history for a record of prior anesthesia issues, and look for any medical, surgical, or other causes for a difficult airway. Often trauma, abscesses, rheumatoid arthritis, and mass lesions come to mind. I would then examine first with a general inspection, then assess the mouth opening, the Mallet-Patty score, neck extension, thyromental distance, and jaw protrusion. And if relevant, investigate with a CT neck, nasendoscopy, or lateral neck x-ray, depending on the issues identified. And that's done. I've done that full airway assessment using history, examination, and investigations. Now imagine the cost of not completing this answer in the exam. Forgetting to mention past history could be up to half the marks. And worse in real life, not browsing the previous anesthesia chart could have revealed a previous known grade 3 or 4 airway that could have easily been planned for with a video laryngoscope. So that's that. That's the assessment of the patient. Number 2, aim of your assessment framework, or SSCCT, severity, stability, cause complications, and treatment. Now, we came up with this pretty complete assessment framework during our second part study over a decade ago, and I still use it even now. Even though history, examination, and investigation are great information gathering tools, I feel that presenting the information in the same way doesn't address your aims. Whenever you assess a patient or problem, I would argue that the most important data is how severe the disease is and its stability. Severity often guides management and is linked to morbidity and mortality events, so really, our goal is to make a judgment call about this. So imagine this example, assessing an 80-year-old male with heart failure. You would ask all your heart failure questions about dyspnea, orthopnea, exercise tolerance, edema, etc., and then examine the heart, lungs, and periphery, and maybe review an echo. And at the end of all of that, a meaningful way to communicate this is the NYHA score for heart failure. Maybe you are investigating a disease and you don't know the score. You can just call it as mild, moderate, or severe and still communicate so much information. So that's severity. Stability gives me an idea of how rapidly the disease can deteriorate, so obviously relevant to whether this patient needs to be stabilized prior to elective surgery. Now imagine our patient having objectively NYHA 1 or 2 heart failure, but currently having uncontrolled thyroid dysfunction or anemia. This ability to suddenly deteriorate means everything when we need to consider whether to proceed with surgery or postpone and stabilize. So that's severity and stability. Now, cause and complications is about looking back to what caused the disease and then forward to the future, what this disease is doing or could do to your patient in the future. If I assess my 80-year-old patient's heart failure alone and forget to check whether this was due to something needing further investigation, like myocardial ischemia, or reversible, such as anemia or thyroid disease, I'm again missing a deep part of the problem. Each disease has its set of causes, and I need to search for these. Each disease also has its set of common complications. So in this heart failure example, failing to look for something like renal impairment leading to high potassium could have lethal consequences, especially if I gave suxamethonium to this patient. Or maybe the heart is now dilated, leading to atrial fibrillation, and now I need to check for the need for anticoagulation and how to arrange cessation prior to surgery. So complications are vital problems to identify. So that's SSCC. Finally, T for treatment. The reason I specifically think of treatments is that we have so many treatments with serious side effects and complications that these are worth noting. In this case of heart failure, the electrolyte imbalance with diuretics or the implantation of a pacemaker are things to look for that could dramatically change my anesthesia management. Patients are not always the best historians, so I need to be thorough in searching for these treatments and their potential complications. So there it is. After a thorough history examination investigations, I communicate this information by stating the disease severity, stability, causes and complications, and the relevance of any treatments and their complications or side effects. SSCCT. Now, just to complete this assessment, the cancer assessment can have its own set of challenges and nuances. So I think of the 5 M's framework, which is mass or mass effect, METs, metastatic disease, medications, metabolic, and mental state. Again, it provides a great framework to add relevant information in a Viva, short answer question, and things to search for in real life. Now imagine an unfortunate patient with a mediastinal mass. Not only do I think about SSCCT, but I can't forget about the mass effect. Is it neovascular respiratory structures compressing life-giving organs? Or is it adherent to large vessels and at risk of causing catastrophic blood loss? Metastatic disease? Does the colon cancer patient have mets to the lung affecting oxygenation and ventilation? Or medications? Is my lung cancer patient on bleomycin and at risk of ARDS with high oxygen administration? Or maybe they're on immunosuppressive meds and at high risk of surgical infection? For metabolic, is the bowel tumor actually carcinoid and about to cause incredible instability of blood pressure and even bronchospasm? Finally, I always consider the mental state of a patient going through the most difficult time of their life. So that's the 5 M's: mass, METs, medication, metabolic, and mental state. So causes of anything, or SCANDIT. SCANEDIT. I must admit that I don't use this often in real life practice, but as a technique for the written exam, it can be really useful. For example, if asked about what you want to know on airway assessment, I can very quickly talk about past anesthesia and any surgical, congenital, autoimmune, neoplastic, endocrine or drug, infective or trauma issues that are relevant. Usually these don't need a structure in real life because they're very self-evident on presentation, but can be a useful exam technique. So that's scanned it for the cause of anything. So after assessment, there's a lot in the anesthesia journey, and the mnemonic passed down to me and now modified is scope, PRIMADE, time, AD. So to fit this into our pre, intra and post-op framework, pre-op is assessment that we've just gone through, and scope, SCOPE. Intra-op is PRIMADE time, PRIMADE and post-op is AD. Let's go through this in a bit more detail. Now, imagine you ask a really broad question in the exam. This ensures that I cover absolutely everything. Imagine a short answer question that asks about a heart failure patient undergoing a laparotomy for bowel cancer, presenting to a small peripheral hospital after a significant episode of PR bleeding. And say the question could be something like, what are the anesthetic issues? After a thorough assessment and summary statement, I could write pre-op, intra-op, and post-op as headings to my answer, and write the letters scope, PRIMADE, time, AD in the margin, so I remember to write a comprehensive answer. So let's go with scope. S is for suitability. This requires urgent transfer to a tertiary hospital with blood bank, and ICU, and oncology service. You may also think about futility, palliation, and whether the patient needs surgery at all. C is for consult. I'm thinking about consulting with a medical team about optimizing heart failure, ischemic heart disease, atrial fibrillation and renal issues, and also with the surgical team. So now encompassing a lot of the surgical issues in this one area of my journey. So with the surgical team, I'd consult about the time of the case, blood loss issues, positioning issues, do they need antibiotics, DVT prophylaxis, and any other equipment relevant to the surgeons. For example, cell saver, any special airway devices, a throat pack, avoidance of paralysis, or whatever is relevant for that particular surgery. O is for optimize the patient, which in this situation means transfuse and resuscitate. P is for pre-med, and maybe you might give a beta blocker if the patient was tachycardic and in danger of ischemic heart disease, maybe midazolam in the anesthetic room for lines placement, and in pediatrics this is always relevant for the anxious child. E is for explain or consent of the patient. So that's scope. And essentially, between assessment and scope, that's all of your pre-op issues. Intraoperative issues can be broken down into PRIMADE time. Let's go from the beginning. So P is for positioning, and this situation is nothing too unusual, but can get a bit more complicated if it's a prone case or a sit-in case. R is for resus equipment, and it's often just a formality, but things to note in unstable cases or in remote environments. I is for IV access, and very relevant depending on the amount of blood loss and the cardiovascular status of the patient, and I always want 2 large bore IV cannulae for an unstable or blood loss case. M is for monitoring, and in this case standard and an arterial line would be relevant, and other types of monitoring I'd consider include CVC, maybe even BIS monitoring, temperature monitoring, IDC, transesophageal echo, and neuromuscular monitoring. A is for assistance, and depending on the stability of the patient, I'll need more staff to manage the blood loss and massive transfusion. D is for drugs, and again it's a prompt to ensure that I think of the right combination of medications. For example, this induction could be very unstable, so I'll need to maintain preload, afterload, and contractility with a combination of the right medications. E is for equipment, and I might add here the need for other specialized kit. If my patient was a difficult airway, the need for fiber optic intubation, for example. So that's PRIMADE. Finally, time, TIME. T is for transport or transfer, I for induction, M for maintenance, and E for emergence. So transfer is very relevant in an unstable patient, so worthwhile mentioning. I've already addressed induction, but you can go into more details, suggesting that maybe a ketamine midazolam induction with fentanyl, giving ephedrine and running metaraminol to maintain preload and afterload and contractility might be worthwhile mentioning. In maintenance, I'm able to offer other points such as the length of the case, particular events during the case, like cross-clamp in a AAA repair, and also analgesia regime. E is for emergence, and is standard here, but again more relevant in cases of difficult intubations or the need for, say, rapid assessment of a neurological state after a carotid endarterectomy. So think about that, that's all your intraop issues in PRIMADE time. Now for post-op. Post-op is AD. I would now think about A, the analgesia plan, and D, disposition. So for the analgesia plan, will they need the acute pain service, a PCA, regional nerve catheters, ketamine even? And finally, D for disposition. Where's the patient headed? Is it the ward, ICU, HDU, or even another hospital? So that's my quick summary of frameworks from start to finish of an anesthesia journey. As you can see, the patient, anesthesia, and surgical factors are embedded within the framework and can still be a useful framework in its own right, depending on the question asked, so use your judgment. In future videos and podcasts, I'll go through the other frameworks, such as the deteriorating patient, basic life support, advanced life support, and problem solving and crisis management in anesthesia. As always, please ask any questions by emailing me at abcsofanesthesia@gmail.com, and feel free to comment and subscribe for more content. See you next time.